All right, well, I think we'll go ahead and get this started. We have good turnout right at the beginning here. So it's great to welcome Neil Sarkar to this population science program meeting. Um, these have been good meetings that we've had over the last year to have different program members talk about their research, and so that we can learn more about what our colleagues are doing, but also have an opportunity to think about new directions or different types of collaborations. Usually for our local speakers, we don't do very detailed introductions, and I think most everyone knows Neil Sarkar, who is the president and CEO of the Rhode Island Quality Institute and has various other university titles at the medical school and the School of Public Health as an associate professor, and he's also co-leader of the population science program. So, we're excited to hear about the work using the health information exchange to catalyze cancer research. Thanks for speaking today.
Great. Well, thanks, Wafiq. It's great to be here. And this is meant to be a discussion. I'm going to sort of start with some just reminders of what it is that we do in biomedical informatics, talk about health information exchanges generally, and then zoom in on what we're doing here in Rhode Island, and then give a sort of a flavor of the kinds of information that we can get at looking at particular cancer types, and then I'll leave with questions at the end and possible next directions. So no commercial conflicts of interest to report. So many of you have seen my presentations where I include this slide where it's, the promised future. This is, of course, the Jedi Library, and the most remarkable medical marvel in Star Wars is, of course, the rebuilding of Darth Vader. And it really is, we're supposed to have caught up to this by now. And so some of the big questions now are where we're at in 2020, how much information is out there? And what kind of information is out there? And what role do libraries, whether they be a virtual library like Google, a physical library that has books and journals. Many of us still remember fondly card catalogs, or maybe not so fondly, and in between. And when we think about medical records, in many ways, clinicians treat medical records and a collection of medical records as a library of knowledge, whether it's knowledge about an individual or knowledge about a population. It's from that then we can use for guiding future innovations. And of course, not to pick sides, where we are right now is we're putting together lots of electronic health records, and on the other side of Star Wars, of course, you're either a Star Wars person or a Star Trek person, and I'm not going to pick sides on this. I like them both. And so on the Star Trek side of things, the idea was you put every piece of information together and then you turn it into a holographic doctor. The reality, of course, especially for the practitioners in the audience, medicine, there are some facets of medicine that you can basically follow a standard template and it works, but there's a lot about medicine that's not quite just about information that has to be retrieved. It's retrieving the right information at the right time in the right way, and then accounting for context and so many variables that honestly nobody has time to write down in the medical chart. And realistically, we don't need to write it all down in the medical chart. And yet we have this sort of challenge now in contemporary medicine, what's referred to as a documentation burden, which has been around for a long time, as was around on paper, but was much easier to ignore on paper. Now, with documentation being required in electronic charting, there are tools that communities have put in place. Well, we won't pay you if you don't fill out these types of data. And that actually is a source of much angst in the medical community. So as we go forward, we think about the future. And the future is a bridge between genomic data and clinical data, and yet we've been talking about this since the Human Genome Project, now coming up close to 20 years since the human draft was complete. And there's still a huge gulf between how we can leverage genomic data and how we can combine that with clinical data. We've made huge strides nationally and internationally. The projects that are launching into their next stages, like the All of Us initiative in the United States. There's also the eMERGE consortium. There's lots of snippets of progress, but we still don't see a true integration of genomic data and clinical data that was always sort of the dream, and there's many reasons for that. Some of it is just how we do medicine. And how medicine is practiced, how we evaluate it. And the National Academy of Medicine, formerly known as the Institute of Medicine, has thought a lot about this. They have a whole series of books and workshops and reports on what they refer to as a learning healthcare system. And that's a term that many are adapting now for where we should be going. And simply put, it's going from the more classical science to evidence to care to being more of a cycle. And there's a cycle where science leads to evidence, which leads to care, and that care actually gives us the foundation for more science. And it's actually a much more cyclical process. And what that really means, simply put, is for every individual who interacts with healthcare as a patient, we are learning from that individual. And that means that when the next individual comes as a patient, we are able to offer the best quality of care with the best amount of available information at that time, and based on everything that we've learned about patients like that. These are all wonderful things to dream about and talk about, and the reality still, however, is a lot of this is a person behind a curtain. There's a lot of promises being made. There's a lot of hype behind the electronic infrastructure that's been put in place. And we really, I think, are challenged with the promise versus the reality, and making sure that we're managing that in a realistic way. So as grounding, clinical decision support and medical informatics or biomedical informatics has been a discipline that's been around for more than 50 years. It really focuses on 5 major areas, and what we call clinical decision support. It's ensuring that we have the right information, getting to the right person in the right format, in the right channel, and at the right time in the workflow. And if we were in a room and I were to go around and ask, how many of you use LifeChart in a lifespan facility? Or how many of you are using eClinicalWorks in your practice? And I'll ask you, of you, how many of you love your electronic health record? And for those of you who raised your hand, I'd then sort of look at you quizzically and go, really? What do you love about it? And for those who do say they love their chart, they say, well, it produces the information for me in exactly the right way at the right time and helps me manage all this information. It makes my life so much better. And then the others in the audience would say, no, the medical record has made my life horrible. And I get these things that block me from doing anything. And I have to keep clicking buttons and moving past one spot to another. And that's really a reflection of we're probably producing the right information to the right person, but probably not in the right format, in the right channel, and definitely not at the right time. And a good implementation of an electronic intervention considers those last 3 bullets the most important. Unfortunately, because of the rapid deployment of electronic health records in the United States, we didn't spend a lot of time about understanding what format do clinicians, whether it's a nurse, a doctor, physician's assistant, a care manager, what format they want the data and how they want it and when they want it. And that actually has led us to much of what we call the moral injury that the electronic health records have imposed on healthcare. So as many of you are aware, and as I'm alluding to, the United States has invested a lot of money nationally in electronic health records and integration of those records and development of networks for connecting across various electronic health record systems. And some of this story goes back to in the mid-90s when electronic health records were really only available at top tier academic actually built their own electronic health record systems that were designed basically by the clinicians for the clinicians. And we went from that to where we are now. And the reason is that America wanted to be, as we are with everything, at the cutting edge. And we wanted to ensure that research and academic medicine and community medicine had all the right tools. When you looked around the globe at that time, in the early mid-90s, the United States was in the bottom quarter of the world in terms of electronic health record availability. And that really struck a chord with the US Congress, with the president at the time. It was President Bush, and he, in his State of the Union address, said, we need to get every American access to a clinician who has access to an electronic health record. And that was pretty profound. And shortly after him, President Obama similarly built on that and said a major part of the Recovery Act needs to be the deployment of electronic health records. And so we immediately went in the span of about 3 years from bottom quarter to top quarter to definitely the top 5% of people who are using electronic health records or have access to an electronic health record, which is wonderful. The only challenge, however, is that we deployed it in such a way that the thought and into those last 3 bullets that I have on this slide here, the format, the channel, and the workflow, didn't really get as much attention as it probably should have. And we're realizing that now. And when you go around in places where electronic health records and their current versions have been available for maybe 10 years or so, there's still very little satisfaction in the practice of medicine because of the electronic health record. The electronic health record is seen as a major hurdle rather than a major tool for supporting medicine. So right around the end of the Obama administration, the 21st Century Cures Act was passed. And what it basically laid out in the context of healthcare information technology, or digital health, I guess as the cool kids call it now, was defining 3 major things that were necessary and essential to get past that hurdle that we now have. The first is to make sure that data can exchange in a meaningful way from one part of a healthcare system to another part of the healthcare system without any special effort on the part of the user. And the second part is it's not just any information or any piece of information, it's all electronically accessible information should be available for the appropriate individuals. And organizations that have access to electronic health record systems or electronic health and data cannot engage in the business of information blocking. And so data and information now has to be, by law, and actually laws have just been enacted by both CMS, the Centers for Medicare and Medicaid, and the Office of the National Coordinator for Health IT, also known as ONC, that basically states that data and information related to health has to be made available at a reasonable cost. Now, what reasonable is depends on what needs to be done, but generally speaking, one cannot prohibit access for another entity to get access to health data, especially in support of one's care. And so this is actually seen as a major infrastructural step as we go forward. And so I was alluding to, so every president and executive administration wants to put their brand on this. The current executive administration is pursuing something called the My Health eData initiative, which sort of shifts it from not just the providers, but also the providers and the payers, where most of the attention is put, but also the patients. So every patient should have some access to their data upon request, and that data should be made available in a way that is usable and useful for that patient. And that actually gets us sort of fast forward to a time where any of us, when we interact with the healthcare system as a patient, should be able to go in to our care provider or hospital or wherever you're getting care and say, can I have a copy of my record, and can you actually just transmit it over to this other practice? And so for any of you who have moved, Americans are a very mobile population, and you know what a challenge it is to move your health data, your health records from primary care in region 1 of the country to wherever you are in region 2 of the country. It's a huge, huge effort. And in the end of the day, what usually ends up happening clinically is primary care physicians say, we'll just, as soon as the data comes across, we'll deal with it, but let's get started. And some of this is about, can we improve that? So the federal government has put out a very, some would argue aggressive, others would argue optimistic, and others would say it's about time we're actually putting some sticks behind this and actually just making it happen. And so by April of 2022, all of the promises about what electronic health data can and will enable will be fulfilled. And we'll actually get to a point where hospitals, primary care offices, community health centers, payers, patients, providers are all working together to actually support the interchange of information in a meaningful way that's actually able to support care. So this is a talk about health information exchange, which is at the heart of all of that. So if you take all of that information and you say, okay, how do we enable this? How will we get from one place to another? Well, there's an easy answer. We all just use the same electronic health record across the country, which may sound like a possible solution, but there's many nuanced reasons for why there are different electronic health records across the country. Some of it's business, for sure, but there's also specialty specific electronic health records. There's also reasons for why some electronic health records are chosen by certain types of organizations versus others. Most academic health centers, as an example, now have some variant of EPIC, whether it's full-blown EPIC across their entire clinical enterprise or just an ambulatory or just an inpatient, but most academic health centers now have EPIC. And people will ask why. And many are challenged to actually say, well, why? It's not just because every other academic health center has EPIC, is that of the electronic health record systems that are out there, EPIC is actually one of the more customizable ones, which then makes a lot of the clinicians scratch their heads and say, customizable by whom and for whom? And it's really designed to be highly customized by the local provider organization to meet the local needs. And so EPIC, when you go through an EPIC install, there's a significant amount of effort that is put into designing and customizing the system to the workflows that are presented during the implementation time. And Cerner also has a very robust implementation plan, and those are the two largest electronic health record system vendors in the company. Here in Rhode Island, we have about 20 or so vendors across our entire health ecosystem. And one of the other sort of running jokes in electronic health records is if you've seen one EPIC install, you've seen one EPIC install. If you've seen one Cerner install, you've seen one Cerner install. There's a lot of local customization that occurs at each clinical site. So in the business of health information exchange, we look at what are standard things that we can count on that we need to have available for supporting transitions of care. And that's largely perhaps the most important part of what we do in health information exchange is support the transmission of key pieces of information from one provider organization to another provider organization. And there's something called the US CDI, which is the United States Common Data for Interoperability Standard, and basically lays out key elements that one should expect that are available for interchange between clinical sites. And as part of that, there's also electronic health information export certification, which would say that certain entities are available, have functionality available so that patients themselves can download to a device their medical record, basically. And it can't be just a scanned copy. It needs to be something that is computable. And that's where we're heading. And taking together the core standards for electronic health record data, or electronic health data in general, and the electronic health information export certification, we're now entering a very different era. And this is actually, there's laws behind it now, there's funding to support the deployment of this, and this is at the core of what an organization like the Rhode Island Quality Institute does in partnership with all of the healthcare organizations for the region that we serve. And so the Rhode Island Quality Institute serves the state of Rhode Island. Taking a big step back and trying to sort of add some context to electronic health information exchange, the notion of a learning health system is best articulated and thought about by a diagram like this, where data to knowledge is sort of the data that are coming out clinically, being made available and accessible for clinical use, and then put it into practice. So knowledge is then put into practice. And so those are the alerts and the workflow diagrams that we put out for people to actually use and manage data, and then use that in clinical practice. And the part that we typically miss out is the bottom arc of this, which is after you've deployed your electronic health systems and you've actually got clinicians to use them, first question you ask is, do they like it? The next question you ask is, how is this impacting care? Positively, negatively? Somewhere in between. How is it impacting efficiency? Are there areas for improvement? And so that's the bottom part, which in many contexts is referred to as quality improvement studies. And that's a part that actually sits a lot outside of the academic sort of thoughts, which just focus a lot of energy on the top two arcs, so data to knowledge and knowledge to practice. And so now with the learning health system to actually work practically, you have to have that bottom arc, which actually connects the practice back to data, and then you sort of repeat the cycle. So in the clinic, and I've talked about this quickly, but just to put some pictures here, this is when many started in medicine. We had paper charts, they had beautiful colored tabs, they led to piles, led to rooms. And the goal here, very simply, was to vacuum up all of those records electronically with other digital health devices, whether it be a personal device, that we could actually support things like self-monitoring applications, gathering data from home devices and importing that into electronic health record systems, and providers interfacing with that. And then there's lots of pictures of providers, and every single one of them is smiling about their interface to the electronic health record, and it's always on a fancy tablet, and they're very pleased about this. And I'm still looking for those clinicians in the real world, but I'm told that this is what we're supposed to be doing. And this is, of course, not quite what we've ended up with. We've ended up with the primary uses of an electronic health record. They're used, in many cases begrudgingly, for supporting patient care, to support delivery, management, and support. And the reason that they're used begrudgingly, and the reason that a lot of organizations invest in electronic health records, is that it supports this second bullet, billing and reimbursement. And the reality is that's a lot of times what leads to the business decision of how an electronic health record is ultimately deployed. It is a rare clinical enterprise that does not have the chief financial officer have a very heavy vote in terms of what electronic health record system is chosen, and how that record system is deployed, and how that record system is evaluated in terms of meeting the needs. In an ideal world, it would be the chief medical officer who actually had more power in dictating, how will this actually improve patient care? How will this actually improve the delivery of care, the management of patients, and supporting clinicians in the job that they need to get done? And I can get on a soapbox about what the right answer is, and I think it's a combination of both. I think you can't ignore the finances of healthcare. It's a very challenging and complex combination of factors, but you can't also ignore the medical factors. And unfortunately, the reality is, in most places, the medical activities, the clinical impact of an electronic health record is more an afterthought than a primary thought. And I think that I wish we could change the world, and this is something if I had one major thing that I would change, this would probably be it. Is that let's start the discussion with the medical reasons for why we want to deploy an electronic health record, and then come back to the finances. But I look at budget sheets more these days than I've ever wanted to, and so budget is really important. And you look at it at the year end, and for most places that are nonprofits, whether you're a university or an organization like the Rhode Quality Institute or a hospital system like Lifespan or Care New England, you have to look at the numbers, and the numbers really. Meaning the economics of this are very challenging, and so you have to figure out, for this investment that I'm about to make on something, whatever widget I'm choosing, and in this case, the widget is the electronic health record, at what point am I going to hit that equal point where the value is actually equal to the amount of money that I've invested? And what's the challenge with that, and the health economists point this out pretty aptly in noting that the focus on money as the cost is a little short-sighted. It's also there's clinical costs and there's human resource costs. And now one of the major things that we're looking at in terms of quantifying healthcare quality is provider burden. And provider burden and understanding what is leading to clinician burnout. And the number one reason leading to clinician burnout is documentation burden. And documentation burden, as I noted before, has been around for a long time. It just wasn't always forced upon, and it wasn't enforceable in as much of a way as it is possible. It is a disgrace, in my humble opinion, that right now we have so many providers who are all trying to do the right thing, and they're waking up at 4 o'clock in the morning, they're spending the first 3 hours charting, and then they go into their practices, they see their patients all day, and then they come home, they grab a quick bite to eat, and then they spend another 4 hours charting. And the reason that they're charting outside of their clinical interactions is for a number of reasons. Some of it is that charting during seeing your patients right now is a very challenging exercise. And some of that, I think we can do a better job in educating the next generations about how to adjust the clinical interface so that we can have better interactions with patients. But some of it is just a huge misalignment between the documentation that is required for billing and the documentation that is required for patient care. And what you will find is that there is a gulf between what providers are keeping records of during their encounters. That's key for clinical practice. And then what they're recording in off hours, meaning that when they're not in the clinic, is largely in support of billing and reimbursement. All that to say, when we talked about electronic health records, as part of our vision and our goal and our dreams was to actually support these secondary uses. Top of mind was decision support. And now we sort of are spending a lot of time talking about the promise of decision support, the understanding of quality, the enablement of research, the support of education, the support of public health, and the guidance for identifying regulations that we want to use. And that's a real, I think, and some of these are secondary. Some could even argue that many of these become tertiary kinds of areas of focus because we can't get the fundamentals right about just using an electronic health record. And if you want to start talking about electronic health records and their utility, everybody's eyes have already glazed over in terms of whether they want to talk about using electronic health records anymore. And I talked about this a moment ago about the rapid deployment of electronic health records across our country. The bottom right diagram here is sometimes it's shown as an animated graphic where we went from in like 2010, and this is showing up to 2013, we went from a mostly nation where there wasn't electronic health records available to electronic health records being made available across the country. Concurrent to all of this, we've of course had equivalent dreams and aspirations about what we could do with the availability of genomic data. I'm not going to spend too much time to just point out that it's very similar. there's a lot of hopes and aspirations about what we might be able to do with genomic data. I think we were a little naive in the early 90s as we started going down the path of sorting out the human genome. And for all of us who do a little bit of genomics work, it was very telling when in the early 90s, we were all talking about how many genes that we thought the human had. It was like, you know, there's worms out there that have 100,000 genes. There's plants that have, you know, 150,000 genes. We're a very complex species. We must have 150. There was even estimates going all the way up to 300,000 genes. Long story short, when we started actually tabulating, we're still, you know, around about trying to figure out what the exact number is. But there's roughly between 20 and 30,000 genes. That's remarkable. That means that the human genome and actually advanced species in evolution have very compact genomes, but it's because of that compactness that there's a lot more interactions, those interactions between genes that actually, some would argue, I think from an evolutionary perspective, actually leads to a lot of plasticity. Allows for us to do very complex things with a small set of genes, but it's also that plasticity and that complexity that leads to complex disorders. And so it's not one gene leads to one disease, it's one gene, some mutations on that gene, along with a combination of this and a combination of other factors, which lead to a complex phenotype. There are, of course, some genes where there is promise of mutations. So Huntington's disease is a classic example that's oftentimes pointed to. People with certain mutations have a very, very high chance of getting that disease. And there's probably, you know, a few such, somewhere between 20 and 50 such diseases where that's the case. But the vast majority of diseases that we categorize as complex, it's not the case at all. In support of all of that, there's this concept of what's called the EHR-driven, the genomics-driven electronic health record, or in this case, EHR, using the EHR to actually drive genomics work. And this is from a colleague up in Boston, Zach Kahane, who's the chair of biomedical informatics at Harvard Medical School. And when we think about the electronic health record and its availability, we think about genomic data and its availability, you can now start to see the phenotypes that we can ascertain from the electronic health record. And now if you can take those phenotypes and match them up to genetic information, there's a lot of interesting things that we might be able to start doing. And perhaps the most noted project that has made the most strides in this is called the eMERGE project. It's a national consortium of institutions that take electronic health record data, figure out how to extract from electronic health records key information that can be perceived as phenotypes that you can then match up to genomic information. So lots of promises. And of course, what underlies all of this is actually a complexity of getting data out of the electronic health record, or electronic health records in general. And some of this is tied to the part that I was talking about a couple moments ago about electronic health records in general, and their primary purposes and what they're used for. Because of the sort of the skew of billing and reimbursement, much of what's in a chart has to be sort of taken with that as a grain of salt, right? So there's lots of extra documentation that may not be clinically relevant, but is really important to get that billing code to actually stick. There's a lot of peripheral information, redundant information that you have to sort of sift through. And so as you go through an electronic health record, and then you have to not just sort of be focused on electronic health records by themselves, but also say what else is out there that might be relevant to include. So laboratory data, hospital admissions, discharge and transfer data, so where a patient is in the healthcare system, registries, biobanks, electronic claims, and aligning that with research that's published in the literature or in reports, and piecing all of that together, identifying cohorts, organizing that into a computable format and structure, transforming that, analyzing that, and then ultimately, finally ending up with new knowledge that you can actually then put into practice. And so it's easy for me to say in that earlier diagram where I had the top two arcs, and that's what this basically represents, is the top two arcs. You really want to then go from that, from the end of this and back to the beginning. The practical challenge that's in front of us is this is not as easy as one makes it sound. Uh, it's not just about the standards and just about the data privacy and security. There are entire courses or entire areas of the discipline of biomedical informatics that focus in on just one of these areas. It's difficult, it's messy, it's challenging, but we're starting to see strides. The other part that's complicating things is the reality that there's much more than the electronic health record and the direct pieces of data that are associated with an individual's healthcare encounter. There's so much more out there. There's things coming from digital health devices, from other digital health sources like Facebook, Twitter. We're seeing increasingly promising studies of tracking mental well-being, for example, through the way one is tweeting and what they're tweeting about. There's even studies that show the ability to predict someone's at higher risk for opioid use disorder based on a pattern of tweets or Facebook posts or searches, interfaces and interactions with other parts of society. So if you're looking at incarceration records, actually might be a sign, not so much of an individual having a lot of problem with the law, but maybe that's a person who actually has a substance abuse problem. And that kind of information we're trying to sort out how do we piece that all together into a way that's available and actually clinically actionable. And that's actually probably the biggest challenge, right? And so everyone gets excited about all the data that are out there. And in my interactions with many of you, as well as others in the healthcare community, both in our state as well as nationally, but especially in our communities, people go, Neil, it's wonderful. People like you talk about all the available data that's out there. But all I want is the med list. I just want to know, for this patient that's in front of me, what medications are they on? And a number of you have heard me on my diatribe talking about the importance of the med list and getting it right. And I find it actually an embarrassment of technology that we don't have better medication reconciliation and medication reconciliation done at the right time. Equivalently, the problem list. Why don't we have very good, sound problem lists that are available at the time of need, especially during a transition of care? Allergies, immunizations or vaccinations. There are key things that clinicians depend on interaction, and all this other stuff. It's exciting, it's wonderful research, don't get me wrong, but clinically right now, people don't care. They want to know what's needed for that patient right there at that moment. And I think that there's an opportunity to say, yes, there is a very acute clinical need that you have right now, but some of that can be informed with some of this other information and maybe guide some of that clinical discussion. And that's where a lot of the research is actually starting to focus in on now. It's looking at all that ancillary information. How do we know when the right time is to invoke a PHQ-2 or PHQ-9 to actually do a meaningful clinical survey of an individual who should probably go through a screening because there's other signals. And we're starting to see promise. So as I know, I mean, the world is becoming increasingly digital. We're all now experiencing, due to the current situation, we're experiencing the wonderfulness of the technological infrastructure that we have as a nation. And there are parts of the world that are not as fortunate as we are here in the United States and in Europe as examples. But in our world, it's truly an amazing time to be in healthcare and seeing how healthcare is leveraging technology in new and creative ways. Telehealth, from the very beginnings of biomedical informatics, telehealth was always thought to be. That's the main reason for why we do what we do in informatics. And it was always put to the wayside, but here we are now, and telehealth is actually a very powerful tool. And now we're at this point where, as we start to return or plan for return to a time when our COVID-19 is hopefully an endemic or a memory for us, we have facets of things like telehealth that we're able to keep because it helps us manage patients in a meaningful way while not taking time away from patients who do need to be seen in person. So interoperability, and this is sort of the crux of what I want to talk to you about today in terms of health information exchange and what we're doing. And so this is a cycle that talks about where digital transformation will come from and how we will do it. It all comes down to interoperability. I'm going to take that diagram and flatten it out. These are slides that I've stolen from Deloitte, which actually has done, I think, a pretty nice summary of looking at digital health, health technology, how it's potentially broken up and looking at the future, and really from an interoperability lens. And so I'm focusing a lot of my energy on looking at those three boxes on the left there. So the data conveners, the science and insights engine, and the data platform and infrastructure builders. That's what health information exchanges focus their energy on. Then you move over to the gray boxes, which are putting that into actual, what are the tools and the resources that we need to actually put into place. And then on the far right are actually the tools that we use for implementing those in the context of a care delivery setting. And so, and it's a virtuous cycle. So while the previous one is a nice cycle of showing how all these things fit together, it's nice to see these as three buckets. And so, if we were in a room together, I'd put this slide up and I'd ask half the room to think of a black horse with white stripes, and the other half of the room to think of a white horse with black stripes. All of you, as very intelligent human beings, will, regardless of which of the two formalisms you were told, will say, got it, it's a zebra. Computers are not so smart. Now, for the embryologists or the biologists out in the room, zebras are black horses with white stripes, but that's neither here nor there. But nonetheless, as humans, we're able to make that connection with very little effort. And in fact, it's remarkable when you watch children, 2- and 3-year-olds, they can make these kinds of links. And the poor computer can't make a sense between the number 7 and the spelling of the word 7, unless it's been told explicitly that those are two exactly the same thing. So that in front of us is the challenge of what we are trying to address with interoperability. And so interoperability means that there's a couple of levels, and HIMSS is the major organization that looks at the sort of the technology side of health IT implementation. So there's foundational interoperability, which means you have the pipes that allow for the data to flow. Structural means that there's actually a format that those data actually move around in, and we do pretty well. We have pretty good structural interoperability now. Foundational interoperability, we have networks, that's actually all pretty solid. It's the semantics that things get lost. And it's one of the reasons why, for any of you who have maybe interacted with Current Care, our state's health information exchange, it requires a lot of human interpretation. And that human interpretation is what we think about as semantic. It means that in order for the computers to really understand it, there's this stuff that has to go on behind the scenes and translate things into codes that are meaningful. And really getting to this point that humans are really good at this. If I write down high blood pressure, high BP, hypertension, or HTN, the clinicians in the room may have other acronyms or abbreviations that they use. They'll get it, no problem, right? Computers, not so much. You have to explicitly build those connections out, and that is one of the biggest challenges. So we did a study a couple of years back looking at the health information exchange here in Rhode Island, and it was meant to be actually a study looking at analyzing practice workflows in a clinical setting. In this case, it's the emergency department, and seeing, well, what data can we use from the health information exchange to support that as a research endeavor. And Margie, who was then a medical student, and she's actually continues here as a resident obstetrics and gynecology, set out to do what we thought was going to be a really neat, data analysis study, stumbled on something really simple, which was just getting the demographic information out from the electronic health systems. And this is actually all from one system. It was from the emergency department at Rhode Island Hospital. And it turned out that there were more than 40 non-standard ways for representing race. And it had to do a lot with the providing systems. So while as humans, you would see a term like white, behind the scenes, it might be coded as 12106-3, the word white, or W. No problem for the human and in the individual data types that are mapped to it within the system. But then when that was exported out, it got exported out as 12106-3, white, W. If you're actually in some obstetric context, which is where some of my other work is in, you'll actually see sometimes a mapping of M and F representing mother and father. All of these make for fun stories, but they make for nightmares when you're trying to actually combine all this information into standard formats. So when we think about how you actually implement all this, there are standards that go on behind the scenes, and mapping all of those. There is a method to this craziness where we do want to have standardized ways for representing things, and there's coding systems. And so, how do we go about doing that? And that's what we do at the Rhode Island Quality Institute. That's what every health information exchange in the country. It's what our primary charge is. And so, supporting population medicine, what we do, as all health information organizations do across the country, so the Rhode Island Quality Institute is the designated regional health information organization by the HIE Act of 2008 in Rhode Island, which means we connect health data, whether coming from a pharmacy, a hospital, from public health sources, from laboratories, from small physicians, large physician groups. We connect all that information in a way that it's available to anybody else in the network for supporting patient care. So HIE, our HIE called Current Care, is operated by us. As I mentioned, was enacted by the Rhode Island Health Information Exchange Act of 2008. Our patients must opt in. And so when you opt in, it's only when an individual opts into Current Care that their data actually flow through the system. That has added some challenges in that, who opts in. And so we always have to ask the question, who's actually in the data set? Turns out that most of the people who opt in are the people who interact with the healthcare system the most. It's people who have chronic conditions. It's people who are older in age. They tend to have more reason to interact with the healthcare system, and they want to make sure that their health data are available at all times that it's needed. We have two major interfaces to the system, one that's provider-facing, that's called Current Care Viewer, and another that is actually patient-facing, which is called Current Care for Me. We have regular enrollment campaigns. We have about 550,000 Rhode Islanders, which is just over a half of our population of individuals who are rolled in. And the data come from across more than 500 sources. In fact, more than 95 to 97% of places where healthcare data originate from, those data actually flow through or have the potential to flow through the health information exchange. We have, as you might imagine, particularly for a state of our population, very controlled access that's defined by the HIE Act of 2008. We have data use agreement processes and policies that are in place. We audit people who have access to Current Care, what they're using it for. All the standard rules that would apply in a healthcare setting apply here as well. Some would actually think of us and do refer to us as sort of the state's electronic health record. And that's a little bit of a leap. We're the state's collection of electronic health record is probably a little bit more precise. And so we have the potential to have every individual who's in Rhode Island and all of their health information data. Now we have two lines of service. One is the Current Care, which I was just talking about, Health Information Exchange, and the other is we have individual relationships with all the hospitals in the state for tracking individuals as they go across the system, or they interact with the system. So if a person gets admitted, discharged, or transferred, we actually have that available as an additional service, and there's some additional clinical information that we're able to get from that, but it's not the full electronic health record. So I thought I'd make this germane to what we were talking about here. So how could we use this in our group and what we're looking at doing for cancer research in our state, and we talk a lot about bladder cancer. We have one of the higher rates of bladder cancer per capita than many other places in the country. And so how many of those individuals are represented in our database? And so I went in and had my team do a query. And here's sort of the breakdown of the number of individuals for whom we have data flowing through either current care or non-current care through the health information exchange. So the way you can think about this is that the non-current care is just the interactions with the healthcare system, so the utilization with the hospital systems. Current care, for those individuals who are in current care, we have a portion, or perhaps in some cases even most, of their electronic health record across multiple sites, whether they went to a CVS Minute Clinic or they went to a hospital or they're in a private physician's office or a community health center. We have all of that collected together and aligned for those individuals. And so pretty good coverage, I think. And so we looked at this, then broke it out into population, sort of the regions of our state, and said, you know, what's the prevalence for individuals who we have somewhere in our health information exchange, whether it be current care or non-current care, and what's the total prevalence normalized to census data. And these numbers actually match very, very closely to what the federal numbers suggest. So at cancer.gov for what we have here in Rhode Island. And so as an example, and this took, you know, about a week or so to just gather the data, organize it, and put it all together. How do we actually, can we actually use this for supporting cancer studies? And so one of the things for us to think about, among other questions, is start to develop a statewide profile of cancer. We could perhaps go through every single cancer type that we know of and develop a similar type of a demographic chart. We can break it out by race, ethnicity, as well as align it with the health equity measures. We're also concurrently looking at the health equity measures that are being tabulated across the state, and lining up care and outcomes to each of those health equity measures. And I think we might be able to do something like that with cancer and both so screening programs. Is there a way for us to leverage data that we have from primary care offices that can be used for guiding screening programs and targeted screening programs in particular parts of our population where we're seeing need for more screening? And actually we could probably get into that workflow earlier. And then after the fact, right? And so after individuals go through a cancer treatment and they're in some stage of remission, what happens to them between the time they come back to the hospital? Or if they don't come back to the hospital, how are they doing? Can we track them through healthcare? And there's opportunities for us to do that as well. And overall, I think, you know, there's such great opportunity. We're starting to realize this now ourselves. And I didn't talk about COVID-19 because I spent a lot of time talking about COVID-19. I took the opportunity today to not spend all the time talking about COVID-19. But we're using it as a way to identify cohorts and healthcare utilizers that we need to put a little bit more energy on. And we could also use those kinds of techniques for supporting targeted clinical trial recruitments across our state, and use it as a statewide population-driven approach for clinical trial recruitment, which I think would be a little different than how a lot of other places are doing clinical recruitment. And so with that, I'll pause. I think I have a few minutes left for question. I see Namesh put a question in the chat. And so recommendation for how to send results to aid downstream research. I think yes, and that's kind of what we are trying to do, which is, so the question is there an opportunity for us to look at the kinds of data that we can access, say information that is flowing through a HL7 message of some type? Can we interface that with other types of information for supporting research? The short answer is yes. the technical answer is definitely feasible. The hard part will be resources, time, and sorting that out. But that's definitely top of mind for a lot of where we are thinking. And actually, one of the other pieces I didn't talk about is we also, as a health information exchange, have the ability to push information back into a chart. And so we have actually the early workings of that with Lifespan. We're able to take pieces of data and actually push it into Life Chart for supporting downstream clinical activities as well, and as well as research.
Thank you very much, Neil. I have a question about, we know, there's some companies out there like Flatiron Health and others that are trying to capture electronic health data to create real world cohorts, et cetera. How is what you're doing either similar or different from what these companies are trying to do elsewhere?
Yeah, it's very similar. And Amy, when she was at Flatiron before she went over to the FDA, really there was a lot of natural synergy there between the kinds of things that we're talking about, and organizations like Flatiron really put out a lot of the infrastructure that we've been talking about here. I think the difference, though, is many organizations, companies like that, and ventures like that, are trying to solve a generic problem everywhere. Whereas we are able to tap into what we are already funneling around for a clinical purpose. And we're able to actually basically put a straw into the side of what's being used for health information exchange for clinical purposes, and actually get out of that things that we could support for research. So the principles, the standards, and actually all of that's exactly the same. Much of what we were doing, it's the access to the data and our ability to leverage it, that's where the difference is. And I think we're a little bit farther along because we have a very specific population that we can focus in on, whereas organizations like Flatiron and others, they're trying to build, and they look for clients to attach into their system, as opposed to us, the data are already flowing.
I think we if anyone has questions, just unmute yourself and go ahead and ask Neil.
Nimesh here. Can you hear me?
Yeah.
Okay, great. Sorry, probably my question was not clear, but I guess what I was trying to say is we want to upload the genomic information to Epic. So my question is, from your perspective, in order for you to work with the data, I'm assuming the best way for us to do it is to upload it in a structured format, but we're not doing that now. So from your perspective, what's the best way for us to provide that data so that way you could work with it?
So into an HL7 message, I think there is a standard for genomics data. Yeah. And what comes to the health information exchange, most of our data come in the form of a CCD. So I think that, which is a continuity of care document, and I think there could be a discussion over what data we want to put in, that's getting put in into Epic, and then how we would put that into a portion of a CCDA document that could then be used for downstream use. Okay. It's a little complicated because the standards, while they're there, they're not really well. They're not commonly used to actually support, I think, what you're wanting to do with it. But I think that there's probably a boutique solution that we could probably think through.
Thank you.
Neil, what does an investigator do if they have an idea or a project in mind and would like to use some of these resources? Do they just contact you, or are there online ways of doing things? What should people do?
Yeah, so you can contact me for sure, but then what I'll do is I'll forward you on to the Advanced CTR program. So we've set up the infrastructure with Advanced CTR to create data sets, and the way it works is we do first a query of we work with you as an investigator and say, well, what patient population you want to look at, what's your inclusion criteria, what's your exclusion criteria. We'd return counts, and so if that's to say we have these number of individuals in our HIE with full longitudinal data. Are you interested? And then if so, then what we do, then we would go through and pull the rest of the data out and then make that available through advanced ETR. And there's a dedicated compute environment, secure compute environment at Brown that these data are then made available with the ability to compute on them.
And just to follow up, people might wonder, how much does this cost, or how long does it take? Is this like a core service, or is this a collaboration, or how does this work?
Yeah, so it depending on the complexity of the query, it can take upwards of a few months. But if for most of the straightforward queries, say it's a set of ICD codes, it takes the team about 2 weeks, 2 to 4 weeks to actually generate the counts, and then another week to actually generate the full data set after that. The costs right now, by and large, are absorbed where possible through advanced CTR. And generally, we are able to cover most of the costs through advanced CTR. There's increasingly, as the load gets higher, there can be a nominal cost, but we're trying to get people to use these data for supporting grant initiatives. And so what we would much rather try to do is support the access to the data. I would say between 2 and 6 months for most data requests, we can get the data made available. And then if there's an R01 or some other grant application afterwards, we'd build in like maybe a 3 or a 5% effort of one of the members of the data team.
One other question, is there a capability to compare to, let's say you're interested in a cohort for some study in Rhode Island, and you'd like to compare with other databases elsewhere. Is that possible? I know it's a vague question, but what are your thoughts about control groups elsewhere? Are there other comparable data sets that one could access for those types of questions?
Yeah, I would love to think more about that. I think that's definitely one of the pipe dreams that I have. I think it's achievable. We need to know a little bit more about those other data sets and how we could get at them and whether they are true comparators or not. I think that it's definitely achievable. I do think it's challenging to sort out whether we have a comparable population on our side that could actually be complemented up to support that kind of an analysis. But there's increasing, and something that has actually happened as part of COVID-19 is we're partnering with many organizations across the country, with the National Institutes of Health, to combine our data all together into a common data model that would allow for that. So I'll probably have a more informed answer about a year from now. But things are looking that we would be able to do that. But I think there's a lot of data harmonization and common data modeling steps that get in the way, or that sort of are the hurdle between where we are now and where we would actually be to be able to achieve that goal.
Okay, are there any other questions from anyone? All right, well, if not, thank you very much for this very interesting talk, and good afternoon, everyone.